Then next, we're going to analyze these cues or figure out what could it mean, or they would ask that as what condition are they experiencing or at risk for experiencing, what could cause these findings, or how would I know if this or that complication was happening. So keep in mind here the big picture problem, all right? Keep this whole picture in mind and don't interpret any one thing in isolation. So let's take a look at how they want us to do that here. So, okay, we need to complete this after we get our lab results. So let's add to this mental picture our lab results. We've got a white blood cell count that's a little bit high, a normal hematocrit, sodium is a little bit low, potassium is a little bit high, chloride's a little high, BUN, so we've got kind of elevated labs all over the place. Our glucose is 411, or for those of you internationally, 22.8. And then we've got our blood gas. So we're going to look at this together because this question is asking us to answer that we should recognize that their blood gas demonstrates which imbalance that is likely caused by which cause. All right, so let us go through interpreting this blood gas together. And you guys said you're pretty confident in this, so we're gonna move through it fairly quickly. I know people really like that mnemonic ROME, the respiratory opposite metabolic equal. I kind of like to think through it. We're gonna talk about both ways. So let's first look at our pH, and our pH here is 7.12. Now that is low. So if I'm interpreting this, is my pH low or high? And a low pH is acidosis, right? So we can already get this far. We can eliminate these, and we're looking for the cause of this acidosis. And Yenny, Audra Marie, Gary, Harpreet, you guys are guessing metabolic, well, not guessing. I think you're making a very educated guess at metabolic acidosis. So let's look at that. If we're looking for respiratory opposite metabolic equal, let's see what our secondary imbalance is. So this just tells us about our oxygenation, which we're not really mainly concerned with right now. Our CO2 is normal at 38, and our bicarb is low at 12. So our pH is low and our bicarb is low. So those move in the same direction, or the equal direction. So in that mnemonic ROME, that suggests a metabolic imbalance. And sure enough, if I have a low bicarb, metabolic acidosis. So I'm going to agree with you guys, and we'll look at this one. Now, is it caused by metabolic acidosis, diabetic ketoacidosis, DKA, due to DKA? All right, somebody guessed respiratory alkalosis, and I want to point out this is an interesting thing with ABGs. So if I had Kussmaul respirations, that's that rapid, deep breathing. If that was my main problem, say somebody's just hyperventilating and they're breathing too fast, what kind of imbalance would that cause? That would blow off a lot of extra CO2, right? So we would see a low CO2, and that would create a respiratory alkalosis. So that isn't the cause of the problem here, and that is actually a form of compensation. So because we have a metabolic acidosis, something is broken with our metabolic system, our patient's kidneys and other metabolic processes aren't able to regulate their level of pH and bicarb, and so their lungs have to kick in to try and help. And so they're going to start breathing faster to try and get off all this CO2, which is considered acidic, to kind of correct and compensate. Yes, Rick says Kussmaul's is a compensatory response, not a cause. Exactly. So that is not the trick. It's not really a trick question. It's, do you understand what's causing the problem here and what's helping to fix it? And so you guys are right. This is caused by diabetic ketoacidosis. And if it was hyperglycemic hyperosmolar syndrome, what would the pH say? The ABG would tell us that it's normal, right? Because that's the difference between the DKA, which is the type 1 diabetic acute complication, and HHS, which is primarily the type 2 diabetic complication, because you have enough circulating insulin to prevent acidosis. So you don't have ketones, you don't have acidosis, your ABG is normal. So well done, good job, you guys. I guess I should check our answer. Yes. Okay, good. So yeah, only 70% of our users in the bank got this right. So you guys you weren't kidding. You guys know your ABGs. Awesome job. And so remember, if you don't remember DKA, the way this works is we don't have any insulin being produced in DKA. That means you have glucose in your bloodstream, but it can't get into the cells, so it builds up in the blood. So it's low in the cells and really high in the bloodstream. So your body can't use it for fuel and starts metabolizing fat and protein really from your organs and tissues instead. So that has an acidic byproduct called ketone bodies that build up in your blood, and we have all this fat wasting, muscle wasting. That's why he looks so skinny, is because he's probably been surviving off of his own organs and tissues for a couple of months now. So we're going to see acidosis, and then from that really high glucose level in the bloodstream, that creates something called osmotic diuresis, where just because there's so many particles of sugar in the blood, it starts pulling water out into the urine, and so then they get dehydrated. So we're going to see these two things with DKA, acidosis and dehydration. And I think you guys see those findings in this patient scenario.